MasterClass, and we are extremely honored to have Professor Celia Chen with us. Professor Celia very graciously agreed to join us live. She's joining us from Australia, where it is close to midnight, but she was very happy to be live interacting with all of you here. So thank you so much, Celia, for being part of this program. She's an associate professor at Flinders University, and she's a very well-known neuro-ophthalmologist. She has been a regular speaker at numerous international conferences, and I'm sure some of you would have heard her in Asia Pacific Academy of Ophthalmology. So she got her training with Dr. Neil Miller at Johns Hopkins University in 2006-07, and since then she has been active in academics in neuro-ophthalmology. So welcome, Professor Celia, and thank you so much for joining here. Over to you.
Thank you very much. And thank you, Rashmin. And welcome, everybody. It's my absolute pleasure to be here. Rashmin asked me to talk about non-organic visual loss. And I think this is a very interesting topic because, firstly, whenever anything has more than two names, I always find that that's because we don't know everything about it. Some people use the word functional visual loss. Some people use the word non-organic visual loss. Now, our aim in this situation is really, we are suspicious that something is going on more than what the patient claimed to be. And in this situation, the definition is there's a subnormal vision when no underlying pathology with the visual pathway can be found. Now, it is a clinical diagnosis. It is not an investigational diagnosis. And it starts with a clinical suspicion that something's a little bit funny, it's a little bit out of place here. The approach is we're here to demonstrate that this person really has got better vision than he or she claimed to be. Now, there's an index of suspicion. I'm not trying to say that we should be suspicious of everyone who walked through the door, but when the signs and the symptoms don't mix, that's when you start thinking, is there something else going on? And what I hope to share with you today is how to approach it in the clinical setting, especially as residents. What happens is that those are the difficult cases. And what happens is that before we present it to our bosses, to sort of start with some of the tests, which tells us that, okay, is there something going on? And very importantly, as I said, when scientists, they say their vision is 6/60, which is not a 6/60 cataract, which makes you start thinking, all right, am I missing something? And very commonly, these patients have what we call a non-organic overlay. So they might have some pathology, but it just seems like the loss of vision is really out of proportion. Now, before we talk about some of the tricks, what I want to share with you is that I said it's a clinical diagnosis. Now, it is not a diagnosis or exclusion. It's not that you've excluded everything else and then you call it functional. Okay, so you really do have to actively try to show this person really has better vision than what he or she claimed to be. But before we do that, we need to also think about some of the conditions where a person may have occult visual loss. And when we say the word occult, that means it may not be quite apparent to us. And in this category, some of the things include maculopathy, Perineoplastic syndrome, vitamin A deficiency, and white dot syndrome. The maculopathy, top on the list are chloroquine, because just like in the textbook, everybody talk about bullseye maculopathy. In the very early stages, like in that, a lot of times we don't see that typical bullseye. And in the early stages, sometimes it cannot, sometimes it's very, very subtle. Just like in this case, this is a person who has got bullseye maculopathy, but if you look at it initially, in the early stages before it develops into that, it can easily be mixed. And very interestingly, with what happened this time last year with COVID, where there were lots of people using megadose hydroxychloroquine, we are increasingly seeing a little wave of that. Now, what about Perineoplastic syndrome? Now, it is a visual loss from a reaction to the original cancer, and that then attacks the retinal cells, whether it's in the photoreceptor layer, and the typical ones are what we call CAR, cancer-associated retinopathy, or melanoma-associated retinopathy. They do still exist, okay? And the diagnosis for that classically is with electrophysiology, where you see a negative B wave. And on this topic, I think, and sometimes you can have more fancy investigations called multifocal ERG, where you then have got the different zones and you see the depression right in the very center. But on this topic, before we talk about functional visual loss, it's important that when you are excluding those occult visual loss, electrophysiology is your friend. And when you order them, make sure that you order your ERG and VEP together. Now, this is a little table that I learned from my days at Johns Hopkins, and I'm sure Rashmi might have got a similar table through our teaching, is that if someone's got normal vision, then your ERG and VEP should be normal. But if someone has got abnormal ERG, but the VEP is normal, then that tells you the problem is at the level of the retina. And if the problem is in the optic nerve and beyond, then your ERG should be normal, but your VEP should be abnormal. Okay, so in this situation, if someone has got normal ERG and VEP, and yet they claim they cannot see, that's also when you start suspecting, is there something going on? Okay, so the examination really starts from the person they walk into your room. And sometimes you get an idea. I've had situations where, for instance, this woman walks in and she's got this very caring husband who is literally overprotective of her. Or you sometimes have people who deliberately, try to fall down and blame you for it. So sometimes even that dynamics really tells you, is there something going on? In my waiting room, I started looking for sunglasses sign. I always get very suspicious when people wear sunglasses indoors. And I think, I know that in India, it's probably not a common thing for people to wear sunglasses. But I think in any cases, if someone's wearing in the waiting room, you start getting suspicious. Now, one of the tests I found very useful is when we are thinking about functional visual loss, we are trying to demonstrate that the vision is better than what this person claims to be. So I'm trying to, we're trying to, in a way, treat them. And sometimes you preface it. And one of the things I found very interesting is that there are a few things we do with proprioception, which is with touch, which we actually don't rely on vision. Okay, so you can do this right now as a fun thing. Just close both eyes and then try to touch your finger together. You notice that you can still do that. Why? Because when you close both eyes, you're using your proprioception. And I usually preface them. I say, okay, so this really only happened after this injury and you've never had problem with your coordination before. Okay, well, let's have a look at your coordination now. Try to put your finger together and you preface it to them to say, okay, you didn't have this problem before. And what I found really interesting is that they always do this really, really bizarre pass pointing. They'll get really close and then, they will sort of miss. And sometimes they start sort of telling you all this story. I'm really trying, and it's quite interesting. This is usually my entry level. Okay, so this is my sort of when I start getting suspicious, I say, well, let's check your coordination. Has that been affected because of your vision loss? And when they start demonstrating that, I'm starting to think to myself, okay, I think there's something there. And that's when I start looking at, okay, how can I try to get their vision better than what they claim to be now? Now, another thing that in a bilateral visual loss, someone says, I cannot see at all. And again, similarly, this thing right here called the OKN drum, I know it's becoming a little bit of a collector's item. I still have one. And very interestingly, in the exams, you see people bringing out various things like a stripy tie. In this day and age, your iPhone, people can now download the OKN app. And that's actually quite useful. Why? It's a natural reflex. So it's a natural reflex for us to fix on that. And then we see the movement in the direction of the drum and then a rapid refixation. So, and again, you preface it to say, okay, now, I'm not trying to test your vision. I'm just trying to look at your reflex and keep counting the number of stripes if you can. And that's what I say to them. And I watch their eyes as I rotate that. And I'm seeing this little movement. It tells me they must be seeing it. And that is why they've got that reflex to keep moving. Now, another reflex. Do you like looking at yourself? Okay, and Rashmin would probably remember this is Dr. Miller's room, and I always get very intrigued. He has got this really big mirror, which is sort of facing away on the side. And I have seen it happening once where he's talking to the patient and he's obviously suspecting, and out of the blue, he then brought out the mirror, and the person got this very startled response. And so it is a very strong reflex to look at yourself. It's called the mirror reflex. And so again, if the person has got that fixation looking at the mirror, that again tells you, he or she is actually seeing. Now, so when someone says, now I've got bilateral visual loss, you're really then trying to use some of the natural reflexes and other senses to try to demonstrate that the vision is better and they are actually seeing. What about if it's unilateral? Now, this is a patient who is 37 years old. He's a bit of a rough guy, leather jackets with tattoos everywhere. And he was in a bar, got into a fight. And he said, yep, they punched me, they broke my glasses. I must have glasses in my eye because I can't see after that. And his vision was 6/6 in the right eye and light perception in the left eye. My resident did a visual field before the person saw me. And these people, they just don't click. And when they don't click, you're not going to get any picture. Another very interesting, and we'll talk about visual field in a second because you can trick, and I've done that myself. I can simulate any pattern or automatic perimetry, and this is where we need our manual perimetry. Another thing is that if the vision is worse than counting finger, automatic perimetry is not very useful. Okay, so this person has got claimed light perception vision. He says, no, it's very dim. I can't see the brightness that you're shining. They could not get even the color, the first plates in the Ishihara. But what got me suspicious is no RAPD whatsoever. Now, we were talking about reflexes. So this is one reflex that you just cannot fake at all because it's a natural reflex for us to constrict, telling us the afferent pathway is intact. And so remember our little finger trick, and this is the entry level, as I said. Okay, so I said
this is your good eye. Now I want you to put your two fingers together in front of you.
So we do it with his good eye, and okay, yeah,
good
he managed.
Oh, okay.
And let's have a look
at
try
to open your left eye now, which is the eye you say you not see much. Now we're going to try the same thing, okay? See if you can try to put your two fingers together.
So I've moved his patch and whoop. See that? Pass pointing. Okay. And that's a very interesting thing. They always do this sort of pass pointing. And again, that's my entry level where I'm thinking, okay, there's no RIPD. He's putting it on. Okay. And that's when I had to go and demonstrate that his vision is better than light perception. And I love this test because it's kind of entertaining. And you really still see some really bizarre behaviors. Like this man, he just kept pass pointing like that. Okay. Now, another test that relies on what we call proprioception, which is your touch, is your signing. And again, you can close your eyes and you can still write your name. Okay, so that's when I say, all right, can we just have a look at how is it affecting you? And you preface it so that, you sort of don't get them on the defensive. And you can see this person signs the name absolutely fine. And on the other side, the left eye, which he says he's not seen, he does this really bizarre signature where he's sort of spelling out his name Ray in different, in different orders here. Now, when they say they can't see out of one eye, okay, if you have no vision whatsoever in one eye, then supposedly you will not have depth perception. So this is a Titmus stereo test. And this is, again, quite useful. And again, you preface it to them and say, okay, so you were absolutely fine before these bar fights and you were seen before. Okay, so let's just have a look and see how it's affected you. Okay, you don't say, I'm trying to trick you. Okay, and so we put on the stereo test. So what happens is that you get them to identify the fly, you get them to identify the circle. And again, you preface and say, okay, so this is a new thing, you never had it before. This is a test for developmental problems. So they think, oh, I should be able to do it. And if they are actually getting down to your stereopsis or 40 arc-second, that's equivalent to 6/6 or 20/20 vision. And that tells you there's actually absolutely nothing wrong with that eye. Okay, and so this is quite a useful test, I find, because again, it gives you a idea of what's that level of vision. What about fogging test? Okay, now fogging test, it takes a bit of practice. Okay, what happens is that you actually put a +4 and -4 cylinder together like that. And when you put the +4 and -4 cylinder together, it's a plane lens. So it should be 0 power, so it should be clear. And I start with +4, -4 parallel to each other. And what I do is that I actually stand on the good side of the patient. I say, sorry, this is a bit heavy, let me hold it for you. And as I'm holding, and I just say, all right, let's just see how it's how well you can do with both eyes open now that you can't see out of the left eye. Okay, I know you're going to think I'm a con artist. I'm not. It's just about prefacing them so they are not suspicious. And what happens is that I'll just say, keep reading down the chart. And they think, oh, I'm doing with both eyes, so I should be fine. As they keep reading down, I'm slowly rotating the cylinder on one side until it's 90 degrees to each other. Okay. And when they are 90 degrees to each other, you effectively, when they are at cross seal, it's effectively an 8 diopter cylinder. Try looking through an 8 diopter cylinder. That's what it looks like. So I took a picture right through that +4, -4 seal at 90 degrees. And so as they keep reading down the chart, unsuspecting, and especially when they get down to the 6/6 line, that's when you go, oh, well, there you go. You are actually reading that out of the good eye. Okay. And I recently had a person who claimed in Australia, there's a lot of Centrelink benefit. One of them is vision. And some of these people have done their homework. And one of the person who actually got this disability, and I actually found out the person actually has got 6 or 7.5 vision at least. So this is quite a good test. The only thing is, don't fumble. If you actually start sort of looking like you're not confident and they start closing one eye, closing the other eye, then they realize that you're trying to trick them because you fogged one eye, then you're not going to get very far. At that point, or there was one patient, I put it up, immediately said, oh, you're not trying that again, which means somebody has tried it on them. So then I tend to change tact. Another tact I do is that I put a +0.5 and the -0.5 together, which effectively becomes a 0 lens. And then I say, oh, you still can't see? Okay, then I put another +0.25 and then a -0.25. I'm saying, I'm sorry, I know it's very heavy. We have to use very high power. That's why it's very heavy. But again, it's a plano lens. And you sort of really encourage them and see how far you can get down. So that's another little trick using the trial frame. We got a little resurgence of this functional visual loss with kids not seeing, and I found the +5, -5 really useful. I know I feel like stealing lolly from them because it's very easy to treat the kids, just because we do know more physiology than I do. And a lot of times, as I said, with functional visual loss, we're just trying to demonstrate they're better than what it claims to be. And some of them is actually something very simple where they like the pink glasses that their best friend has. So in this type of situation, not all of the functional visual loss are malicious. And that's also why I call it functional rather than people have words like Munchausen or, or various names. I'm not a psychiatrist and I don't pretend to know anything about it. So that's why I don't want to use the words such as whether someone is malingering or someone is Munchausen. And all we are doing as an eye person, as an ophthalmologist, is we are showing the non-organic component. Okay, now moving on. So we're going to talk about visual fields now. Okay, and in these patients, when you do 24-2 perimetry, okay, and it's actually a very interesting exercise. Sometimes if you actually just put yourself on the field machine, this machine, what it does is that firstly, it actually tests 4 spots, 1 in each of the quadrant, and then it starts expanding around that spot. Okay, so when you get people to do a visual field defects, and similar to inattention, is that they initially click And then they start thinking, hang on, I shouldn't be seeing that. So they stop clicking. That's why you get a cloverleaf pattern, because they saw the initial 4 and the rest is blank. So when you see a pattern like that, you start thinking it's either they're not paying attention, they're starting to fall asleep, or they're deliberately not clicking. Okay, so that's why we call it cloverleaf. Make sense? Okay, good. Now, the whole thing about visual field testing, and this is one time I found the manual perimetry much more useful than the automatic perimetry. The reason is because we know a bit more physiology compared to the patient. So hopefully, okay. I once presented this, and one of the general ophthalmologists, I'm the only neuro-ophthalmologist in South Australia, and someone said, "Oh, we're all in trouble if Celia decides to have a functional visual loss, because then they will have to catch me out." Okay. Now, so say if someone has got loss of vision in one eye, okay, and in this situation, what is interesting is that normally our visual field actually extends 60 degrees nasally. So if you really only have lost vision in one eye, you should only lose that little nasal crescent on the other side, okay, the crescent on that side. So if I really don't have vision, I'll lose that bit, and this is the true visual field loss. But a person who is a lay person would not know that. They think, hang on, if I don't see out of this side, everything to this side should be gone. So what happens in this situation is that you test their perimetry manually. I tend to hold a fixation target, like a pen, and then I have a red target. And then I'll start with their good side and say, all right, tell me when you see the red target, and they will have no problem. But interestingly, when you go to the other side, almost always they get right to the midline and they get a pattern like that. So when you see that, again, that's not physiologically possible. And when it's not physiologically possible, you start thinking something is not right, okay? And I usually draw this in my case notes and say non-organic visual loss, visual field pattern. Another thing which I found very interesting, I love doing, is when I do the visual field at 1 meter and 2 meters. Why? Now, again, we know a bit more physiology than the patient, okay? What's our vision? It's like a cone, okay? So when we see the world, we start from the center and it extends out like that. So what happens is that if I really have a tunnel vision at 10 degrees, when I'm back at 2 meters, my 10 degrees should become 20 degrees, okay? So that's the real pattern. But in those people who have functional visual loss, and again, when you have a fixation target and you got a red pen coming in, and they think that, oh, I should still be at that point. So what happens is that you actually have the same visual field at 2 meters, and sometimes even narrowing in. Another thing that's not physiologically possible is if someone has a fixation and you've got a red target and you cross over the midline. Because if it cross over the midline, that's not physiologically possible. And that also tells us that there's a non-organic component there. So I do find the visual field confrontation very useful, okay, especially the people who keep having that narrowing of the eye socket the further back you are. And again, you preface it to them. I sort of say, I'm sorry, I know it's going to get very blurry because I'm going to be further back. Now, can you still see that red target? You know, and really give them a really big red target. And what happens is I'm really trying to demonstrate where you are in relation to that fixation point. Okay. Now we're getting to a slightly tricky one. Okay. And before I talk about Prism shift test, the way I think about the non-organic visual loss is just know a few and do it well, do it swiftly. Okay. And usually if I have demonstrated at least 2 tests, which shows that there's no organic component, and usually I do visual acuity and visual field, then I'm pretty happy. As I said, the tricky part is always if they have already been to other people and you know they sense that you're suspicious and they got their backs up and they just won't cooperate. They just keep saying, no, I can't see, I can't see. Then you are sort of backpedaling and having to work harder to prove that their vision is better than what they claim to be. So if someone claims that, no, I can't see out of one eye, another useful test is called Prism shift test. Okay, and in this situation, I say, okay, let's cover your bad eye. We'll just give that a little rest now. And unbeknown to them, I bisect a prism. So when I bisect a prism, what I mean is that I put prism with base next to each other. What happens when you do that? And next time when you're in clinic, just put the prism up. The prism actually shifts the image. So out of one eye, you actually see two images. Okay, now you've prefaced it to the person now. The person thinks, oh, I'm seeing double out of my good eye. So it's okay to see double. And this is where you have to do it quite swiftly. Okay. And then while I say, okay, let you just put your hands down now. While they do that, I quickly take one of the prism away. And what happens is that if the person really has no vision, then you can't have double vision when you have only one eye. So then they will only see one image. But if they do have vision in that eye, which they claim to have lost, they will see double. And I just do a very simple thing. I say, okay, let your hands down now and tell me, do you still see one or two? And they are under the impression that they should still be seeing that. So if they do have vision, and if they say, yeah, I'm seeing still two, that tells me, yeah, they got vision in that eye. Okay, so again, another simple trick. And again, this is more just understanding the optics. So in non-organic visual loss, the trick is that we know a bit more physiology and a bit more optics than they do. Okay. Oh, what happens when you caught them in the act? Okay. And don't confront, because you can probably saw like the gentleman a bit earlier with all the tattoo, and I wouldn't want anyone to beat me up. Okay. And as I said, sometimes it's children as well, and it's not a malicious thing. And when they are caught in the act, what I usually do, it depends on whether it's a child or an adult. They are usually down a slippery slope and they're trying to cry out, sort of demonstrate something to you. If it's a child, what I usually do is I usually send the kid out, and I said, oh, my receptionist has got a little jar of lollipop. See if you can find it. And it's quite funny because every time I do that, my receptionist knows, oh, this little kid is a liar. But what's happening is that then I show the mom, I show her the glasses with the plus and minus lens together and say, you see through that, that's actually a clear lens. And so your child is actually reading that, okay, with a clear lens, which means their vision is actually normal. And sometimes the story comes out. Sometimes the story comes out, such as in Australia, for instance, you know, some of the parents are separated and the child goes from one parent to another. And before they go, they always say, my vision goes blurry, to try to avoid. Again, my job is not a social worker or a psychiatrist. My job is sort of demonstrating. And it's very interesting how stories sort of keeps coming out that way. It's also quite interesting that when I was presenting this in one of the overseas forum, one of the doctor has a very funny trick. He says, if it's a kid, I say to the kid, you need total iris, no iPad, no games. And next time when they come, they miraculously all get better. So that might be a little trick for you. But the way I tend to face it to them is that I just say, look, I'm really pleased that when I examine you today, everything looks normal. And in particular, your eye nerves looks very healthy. Okay. And sometimes I, before they've seen me, they've already all done an OCT. And I say, you see that green color that tells you it's in the normal range. It tells me that there's going to be recovery. I just don't know when. Okay. And it's giving them a way out when you say that it's likely to be a recovery. And sometimes, you know, they sort of just need that permission. And that's when I say, I don't know when it's going to get better, but I'm quietly confident that it should get better on its own. Okay. And a lot of times what happens in this situation is I don't confront them, but I do let their accompanying person know. Remember, the exam starts as soon as the person walks in the door. And sometimes there are funny dynamics going on. Sometimes you've got an overprotective parent or partner or spouse, you know, but I do sort of show it to the spouse and say, well, actually, you know, again, when the patient is not there, to say, I think this person is seeing what he or she claims to be, there's something more to it. And so what happens is that they know about it as well, so they don't keep feeding on to the behavior. I had a very interesting one where this girl who is in, she's in the year 12, which is the level about to go into high school, but she's in a boarding house and she just misses her family who live overseas. So she claims that she cannot see. And that's actually her way of crying out to say, I really just want to go back to my family. Okay. In this kind of situation, our job is one, demonstrating it, and two, not over investigating. And I'm sure we can share stories. My maximum number is a person who has had 9 MRI scans and 3 lumbar puncture on the same patient. Now, I'm not saying that you shouldn't investigate. Remember, we need to exclude occult, but in this kind of situation, the MRI is not the cure. Okay. So in summary, okay, with functional visual loss, it starts with a history examination and a healthy index of suspicion. When something is a little bit out of place, when the sign and the symptoms don't marry up, you start thinking, what am I missing there? Is the vision better than what it claims to be? Okay. And remember, that's what we're trying to do. We're demonstrating better vision than what the patient claims to be. We do need to exclude occult visual loss and consider electrodiagnostic testing. And then, depending on whether the person presents with bilateral visual loss or unilateral, in bilateral, your approach is to use the natural reflexes, which include proprioception reflex, OK drum, and also the mirror reflex. If it's unilateral, it actually makes it a bit easier, okay? Because then you got a few more tricks, including, again, the proprioception test, the signing, as well as using visual acuity. We got the fogging test using a trial lens, the visual field test, and also the Prism test. Now, I'm going to end with this slide and see how many people can see what's underneath. LIAR. Now, I'm not saying that you should think every patient who walked through the door is a liar, but I'm trying to say that, again, in functional visual loss, it starts with that healthy index of suspicion, because sometimes things are not what it seems. Thank you very much.
Thank you so much, Celia. I think it was so beautifully covered every nuance from the resident's perspective, from the clinical perspective. It was amazing. Thank you so much.
Thank you for having me. And it's always a bit of a fun lecture. And so hopefully the residents would get a few tricks. And I welcome all the questions which Rashmin said that he will help collect, and I'll endeavor to answer for you. Thank you.
Yes, Rolika, do you have questions?
Yeah, but before we start off with the questions, I would like to ask, ma'am, which was the most interesting malingering story that you ever had in your OPD?
I have a few, actually. How long do you have? And as I said, I have to say, though, it was very interesting that sometimes I get treats. Okay, and I'm sure all of us have stories like that. So I've got this 9-year-old girl. She claims that she could not see. And look, what came down to at the end was, as we were saying, broken family, and she was having a bit of adversity towards the father. So, but this girl, she totally had me fooled. Okay, she claims that I couldn't get her. I tried all my tricks, and she just would not improve beyond 6 on 60. I even got to the point where I was doing a fluorescein angiogram for her. Okay, but the interesting thing was that it was my technician, who was talking with the girl, and the technician came to me and said, "What has she got?" And I actually said, "I don't know." And this technician was a bit wise and said, "Do you know, my 10-year-old boy can fool me with anything." And so the technician obviously, sort of got something funny as he was talking with the girl and trying to do this angiogram. So that's when I started thinking, he's right. There's something that's not gelling. And so that's when I went back, look at the story and thinking, it just doesn't fit. Optic nerve looks too good. No RAPD. Why is the vision 6 on 24? Okay. And so I had to go back and really try very hard because she's quite a clever girl. And I did every book under the sun. Okay, every trick under the sun, including the plus and minus lens together. And I actually put 6 lenses in front of her, and then eventually got her to read 6 on 7.5. And that's when I got, gotcha. Okay.
No, I had a patient who was being posted in an area where he didn't want to go. he was into a security establishment. So
Mm.
in fact, he kept coming back with both bilaterally dilated pupils.
Okay, yes.
And something which, after all thorough investigation and workup, we couldn't explain. And then when we went into the history a little bit, we realized that actually he had
Atropine.
read on the internet, and then he was using eye drops before for the checkup.
I know, yeah. And
That
people probably thinking, oh no, something really serious with the brain. There was a very interesting case. In fact, Prem presented that in the neuro-ophthalmology meeting. And what happened was that the audience actually gave a very good tip. And this is a good tip for the residents, is that for those people where you think, hang on, it doesn't make sense with the anisocoria dilated pupil that just absolutely fixed, put pilocarpine. If there's absolutely zero response to pilocarpine, then it's a medicamentosa. It is a iatrogenic atropine use. And sometimes in Australia, one very funny story is people give eye drops to their dogs or to their pets, and then they accidentally rub the eye. So sometimes it can be inadvertent. Yeah. Any other questions?
Yes, ma'am. So there are some questions that we have. One question is, did you ever find diplopia as a part of malingering syndrome?
A lot, and it is difficult. So I work with an orthoptist, okay, and diplopia is a huge talk on its own. So I'm very happy if with the residents, because there's a whole approach about monocular versus binocular diplopia. We actually get a lot where it's monocular diplopia, but people just people call it double vision when it's a little bit of ghosting and blur. But we definitely do get a lot of cases where they just kept saying it's blurry or it's double. And as I said, I work with an orthoptist for all my motility cases. And when there's absolutely zero strabismus, which can account for this diplopia, that's again when I get suspicious. Okay, and I do that prism shift test, because they start thinking, oh, hang on, I am seeing double out of one eye. Okay, then maybe I can see double out of this eye. That's when I usually treat them. Yeah.
Okay.
Mm-hmm.
Yes, ma'am. Ma'am, a question is there that is there a test, like any malingering test for Neovision specifically?
Okay, very good question. And in fact, I'll digress a little bit. I was in a meeting when Joyce Liao was the guest speaker, and what happened was that someone said to her, "How do you know whether the child just doesn't want to study versus the child cannot see?" Okay, and she said it's very easy. And she does the OKN thing, which actually then showed up whether or not they're actually fixing and seeing. With near vision, it is very similar to the distance vision. And what we are trying to do is, I think your question, or the person who raised the question, is, could there be an accommodative spasm, or could there be accommodation vergence problem that is causing the near vision problem? If that is the case, we will see motility signs. We'll see things such as reduced near points of convergence. We should see the eye converging in a little bit. Okay, and that's actually a very interesting situation. There was a kid I've seen once where she knows how to induce convergence by pretending there's something on the nose and the eye goes right in. And she'll be in the middle of the classroom, and then she'll have this esotropia, and then she will say, I can't see, and she gets sent home. Okay, and in this kind of situation, the trick is looking at the pupil. So again, think about your physiology. Your accommodative reflex is meiosis, ciliary body contraction, and convergence. So if the person is doing it deliberately, you get the small meiosis, and then the pupil goes in. Okay, so how do I treat them in this case? That's when I am the bad guy. I put the atropine in, because that totally dilate them. They cannot converge, and that's when you can treat them out of it.
That's interesting.
Yeah.
And ma'am, do you see any of the psychiatric conditions associated with vision problems?
I do. Okay. And you can look at it two ways. Okay, some of these people, certain medications do cause them to have vision problem. For instance, the tricyclics and the sulfur medication can cause a ciliary body rotation. Okay, and so then they get a blurry vision because it causes an induced refractive error. Remember, a lot of these people have functional overlay. So then they start saying my vision's blurry. Okay, so we need to then be careful. Firstly, are we dealing with the underlying condition, or are we dealing with the medication that's causing it? So it always starts off by ruling out the vision. And if by refreshing I can't get them right, then I start thinking, are there something else suspicious going on? But to your question, do you mean is there a specific type of psychiatric condition that always present with vision loss? No. Okay.
Right, ma'am. And ma'am, what's your approach to these patients? Like, when you detect visual problems, and you, as you mentioned in your talk also, that you detect a psychiatric component. How do you really approach these patients?
Yeah, and it's a really good question. It's a very complex question. Okay, because what happens is that we're only seeing a snapshot of what they're doing in the clinic. We don't know what goes on behind. Okay, so I'll give you an example. One of the patients who had a functional vision loss, the big guy there, what actually happened was that he just had a baby, and his wife was the manipulative one who wanted him to do that so he can be on disability pension and stay at home to help look after the baby. Okay, so what happens in this situation is, I don't understand the whole complex behind it. And do I refer everyone to a psychiatrist? No. Okay, but what happens in this situation is, as I said, I tend to remove the person out and speak with the accompanying person and say, look, there's something here that doesn't quite fit. How are things going at home? All right. And as I said, I sort of show them the glasses and say, I think his vision is actually better than what he claimed to be. And you start getting a response from the accompanying person. If it's a child, it's sometimes quite easy. If it's a child, it could be, oh yeah, her best friend got glasses and she wants glasses too. But if it's an adult, sometimes it's more complex. In Australia, the referral system is that there's a general practitioner, and they have to see a general practitioner before seeing me. So the GP is the coordinator. I sometimes personally ring, in fact, most of these cases, I personally ring up the GP, because you get a lot more out of the GP just to understand the background as well. And also it's off record as well, where the GPs are more willing to talk to you about what's going on.
And you also have an involvement of a social worker there?
It depends on what's the underlying reason, okay? Because sometimes the social worker, they'll be throwing their hands up as well. It depends on the motive, okay? As I said, I'm not a psychiatrist. I don't know if it's Munchausen. I don't know if it's malingering, okay? Sometimes it's not, they may not have underlying psychiatric things. Sometimes it's actually purely for financial gain because they get the vision disability pension. So in this kind of situation, I think what you're trying to get at is it a multidisciplinary approach? Absolutely. Okay, but it's not a blanket multidisciplinary. There's no such thing as once you detect functional, you refer them here. You do need to tease out that once you detect a functional thing, is the best person a psychiatrist, a social worker, simply the parents, or the general practitioner as your next point of call? I don't, and my job stops there to demonstrate that the vision is better. My job is not taking on the problem and managing the whole lot.
Right. And ma'am, out of all the tests that you mentioned, all the malingering tests that you mentioned, which one is the most important test before you label it as a malingering in general?
Okay. There's no one test that's most important. Throughout my talk, you keep hearing me say, we are demonstrating the vision is better than what it claimed to be. And you also remember I said, just learn a few tricks, do it confidently and do it well, because you don't want to be the one fumbling with the trial frame and say, oh, hang on, so, oh, it's not 90 degrees. Then they will know that you're onto something. So what I find is that I divide them into acuity, field, and alignment. Okay, so the acuity is the fogging test. The visual field is the one where you do the confrontation, and the alignment is the one where you do the prism shift test. So I tend to do at least 2, demonstrating 2 out of the 3 domain has got the functional component. So I will do 1 from the acuity and 1 from the visual field, for instance.
Yeah, actually, so that covers both the components.
Yes.
Right. So, ma'am, another question is that, is hysterical blindness similar to malingering?
Very, very good question. Okay, and hysterical blindness. Okay, if you, I was asked to speak at a psychiatry conference, and I learned a lot because they've got the DSM classification, and they've got hysteria, malingering, Munchausen by proxy, etc. Okay, now the hysteria blindness, again, I don't like using that term. The reason is because that's the psychiatrist term. Okay,
Right.
so hysteria blindness, the important thing in this situation is, again, number 1, exclude the occult visual loss, making sure it's not something which is due to a cortical blindness with the occipital lobe involvement, and then trying to show that they have got better vision than what they claim to be. Okay, and again, back to the functional overlay, I had a patient who has multiple sclerosis, and you know, she was sort of in a wheelchair, a lot of people hovering around her, and then she sort of, basically, she had optic neuritis in one eye before. Okay, she then starts saying that, no, I can't see out of both eyes, but the reaction was just quite dramatic. You know, she's crying, she's, the emotion was a bit out of proportion. And also for someone who is got multiple sclerosis, you know, the emotional effects and all that. And that's when I start getting a little bit suspicious, just because, you know, she's almost like using that as a way to get the whole family to absolutely fuss over her. And, you know, she was closing her eyes saying, I can't see, I can't see. Okay. And then in her, the hardest thing is actually getting her to open the eye. Okay. And when you get them to read the chart, they will say, no, sorry, can't see that, can't see that. Now, remember, this is a bilateral situation. So this is the time when I then try to use the reflex. So I had the OKN drop, and I clearly could see the refixation. So I'm thinking, yeah, well, she's got better vision than claim to be. And you really do have to set the tone, you know, really dim the room light and say, okay, try to open your eye a bit more now, it won't hurt you, and all these kind of things. I feel like an actress sometimes.
I think it's quite interesting. Yeah, ma'am. Have you ever had any of the patients that complain with visual hallucinations simulating malingering?
Very good question. And Lance Liu in Philadelphia has given a beautiful talk once on visual hallucination. Okay, visual hallucination is quite different game completely. Okay, because in that category, we're talking about visual processing disorder. So I, in terms of functional visual loss, I put them quite separate. So yeah, sometimes you got people coming up to you and, you know, really cook up a very good story. But again, if you tease out the story, it depends on what's going on. If it's a visual hallucination, they see something that is not there, or they, that's my approach completely changes. And I don't try to think they are functional and try to treat them. I start thinking there's a visual processing issue, which is beyond the visual pathway. Because remember, the visual pathway, the afferent pathway, once it gets to the occipital lobe, it doesn't stop there. There's a ventral pathway that tells you where things are, and the dorsal pathway to the temporal lobe that tells you what things are, and you know, things like color, etc. Okay, so when it comes to visual hallucination, you need to think about that. And for the residents, there's a really good article called Central Visual Processing Disorder by Christopher Gerken in Survey of Ophthalmology. And that would then give you a very nice, succinct summary about hallucination and central processing disorder.
Okay, thank you for that. There are times when we get in like the OPD, we see patients with painful loss of vision, and eventually we come to like, you know, they're basically malingering, or it's not painful. So in such a situation, when they're trying to create a nuisance, technically, what do you usually do diplomatically?
They are difficult. Okay, they are difficult. In these kind of situations, I separate the two things. I separate the pain and the vision loss. Okay, so the vision loss part we've talked about. So then we try to get the vision better. The pain part, now remember, everything starts with a history examination. So you then exclude anything that could be ocular surface issue. You exclude things such as corneal opacity, etc. Now, I find pain the hardest thing. In fact, some of the, I've once heard a neuro-ophthalmologist say, I don't do pain. We can't do that, unfortunately. It somehow lands in our category. But if you tease out the functional visual loss, whether it's visual acuity or visual field, and then the pain, then it makes your life a bit easier. And if you do demonstrate the functional part, then a lot of times then you're more confident to say the pain is a separate thing. Okay.
Right, ma'am. Ma'am, also there's a question that, for all medical legal aspects,
Yes.
do you recommend doing an MRI when you clinically diagnose the patient as malingering, like just to prove it?
I don't, because what are you proving? Okay, and part of the reason is because usually by the time they've come to me, many of them have had multiple imaging. As I said, my record is 9. I'm sure there are people out there who has who can beat that record. Okay, many of you had heard me say this funny word called vomit, victim of modern imaging technology. Okay, and with MRI technology, people are now seeing a lot of things which we don't know how to interpret. For instance, white matter lesion. Okay, it's been found in 8% of the normal population, and sometimes that increases anxiety. So if anything, I sometimes have seen the vomits, the victim of modern imaging technology, because they get the imaging showing up something when they're absolutely fine, and I don't know if it happens. So in India, there was a funny story recently where, so in Australia, it's a user-pay system, which I'm sure many countries are. And there was a diagnostic center that opened up, and in order to attract people, they bulk bill or the MRI scan. We're getting a lot of funny things going on, and people have the MRI imaging, and they probably see the brain more than what they want to. And I'm getting a lot of the things such as, this person's an empty cellar. Have they really got idiopathic intracranial hypertension? So I order an investigation if I'm trying to find something. I don't do an investigation to exclude functional visual loss.
Right. Ma'am, there's an interesting question that suppose we cannot rule out malingering on the first visit, but there is high level of suspicion here that malingering still might be one of our options. How do you follow them up?
Okay, very good question. And so remember, in that situation, the worst thing is to say, sorry, I can't find what's wrong. See you later. Okay, because then we're not doing our due diligence. And in this kind of situation, what I say to the patient is, look, at this stage, okay, I'm reassured that your optic nerve today looks really good and really healthy. I think things are going to improve, but I think we do need to follow this carefully. I usually give them, I usually do follow them up with an appointment, say in 3 months' time. Okay. And if I have high suspicion, but I couldn't catch them the first time. So what I do is that the second time when they come back, I do tell my residents, I say, okay, this person I want to see myself. And again, you prime it. Okay. So another thing that's quite interesting is that those people, sometimes I don't let my nurses check their vision. I check their vision myself. Why? Because in the automatic chart, I start with 6 on 3.8. And then what happens is that I take them to a different room so they don't get too familiar. Okay, so again, you're just trying different tricks now to try to demonstrate their vision is better than what planned. So I'll start with 6 on 3.8. I say, all right, we're in a different room now, and then they will say, no, I can't see that. I'm saying, okay, I'm going to make it bigger. When you make it bigger, it's 6 on 4.8. I'm going to make it bigger again, 6 on 6. Make it bigger again, 6 on 7.5. All right, and then they think, oh, they've gone quite a few notch up. She's accommodating. I better come. And I've definitely had situations where, as a result of that, I then demonstrated someone who claimed they were counting finger to a 6 on 7.5 vision. So and another very interesting thing is that those onto the thing about working as a team, those difficult ones, especially if you're bringing them back, don't have someone different seeing them, because they get really, they get their backs up. They get really suspicious, and they start thinking, I've done all of that before. Okay, so there's a little bit of a give and take. And as soon as they start getting defensive, thinking, oh, you're trying to trick me out, and they clam up to say, no, I just can't see. No, I'm not doing that. Then you are backpedaling.
Right. So one last question that I would ask is, like, if you're finally, like, after examining the patient, you've sort of come to a conclusion that the patient is malingering, like everything goes in that direction, but still you have it in your head that, okay, I might should not, miss something that is functional loss. What is that one test that you would do, and to be on the safer side that, okay, I should not miss it?
Electrophysiology. Yeah, okay. So as we were saying quite earlier on, is that a lot of these people do have functional overlay, which means they do have an underlying condition, okay? But then the response is a lot more dramatic, okay? They might have something going on, but the vision is not counting finger or hand movement, okay? And remember the electrophysiology, you do both ERG and VEP, all right? If both of them are actually plumb normal, then from my examination, then I can rest easy to say that's fine. But if the ERG is done, VEP is normal, then there may be something in the retina that I have missed. Then I'll go back to that.
Right. Rashmin, sir, do you also have one interesting incident for us?
Yeah,
the malingering story.
It fits in beautifully well, because that's what I had. I had a patient who I had seen in Chennai, and a lot of people, she had seen a lot of ophthalmologists, and all of them had said that, you are basically, in good words, that you are lying and you don't have anything going on, and and a lot of it was blamed on husband, because it was thought that the husband was one of those ambitious guys, and she was having these symptoms to attract the attention of the husband. That's what a lot of people concluded. She came to Chennai, we did all the tests, electrophysiological tests, came back normal. She was observed while she didn't know that she is being observed in the OPD room. And we realized that she when we checked the vision, it was thought to be counting figures, but she was responding. I mean, we would ask an optometrist who always would work her up to go out and wave at her, and she'll wave back from 3 meters, 4 meters. She'll smile back at a distance. So we knew that her vision is surely not counting as 1 meter. So it was fairly clear that she had a functional vision loss. Then cut to 2 years later, and we saw on a Facebook that the husband has changed and both of them are gelling together. And so then the motive which was assigned to her, that because she wanted to get the husband's attention, she was probably faking the symptoms. So we called her back saying, okay, let's see now what is going on. She came back and actually her vision recorded was poorer than what was recorded before. So she went through the electrodiagnostics, and this time, after this is third test, this time ERG showed up a problem, and she was ultimately, by the UVS specialist, thought that maybe some rare form of azure is what is going on. So Celia said that you make confidently diagnosis, but if you're not very sure, or if you feel that there is something which is fishy which is going on, give a benefit of doubt to the patient and make sure that you do all the tests. And as she also very rightly, beautifully said, that your clinical examination, clinical judgment should always be foremost and should be repeated all the time.
Absolutely. And we didn't talk to each other beforehand, okay? So, and I think most of us neuro-ophthalmologists, we all have stories like that. And so it's lovely that we concur.
Thank you so much, ma'am. You actually made this topic very interesting, and you kept us hooked to the screen with your stories and incidents.
You kept me awake, so thank you. Excellent. Thank you. My absolute pleasure.
Bye. Okay. Have a good night.
Good night.